Hello and welcome to our presentation on an initial experience of perioperative medicine, MDM, at the Royal Melbourne Hospital over the last 12 months, and it's very exciting to be able to talk about some of the results we've found today. In terms of background, in the literature there's very few evaluations of MDMs in general, let alone in perioperative medicine, and there are concerns about whether they're too costly or too difficult to run. We thought though we had a lot of very sick and complex patients, and that talking about them and bringing all the skills of the hospital to bear would help improve the outcome. And so we launched the perioperative MDM with the input you can see on screen, and at the same time launched a prospective observational cohort study to try and understand what the frequency of recommendations made by the MDM were, what sort of things drove those, and what sort of cost implications of running an MDM would be. So on to the main result, the primary outcome. We had about 43 patients enrolled, and as you can see, about 50% were recommended to pursue non-surgical care, about 40% were recommended to go forward and have surgery, and the remaining 10% or so were recommended to pursue a shared decision-making treatment model. Of those, there's been some crossover and, interestingly, a relatively high mortality rate in both groups, but this was the kind of key outcome. Where were patients going to end up? To explain some of these results, the cohort that was enrolled was quite elderly with a median age of 77, was quite frail with a median CFS of 5, and were thought by anaesthetists to be fairly sick with a ASA median score of 4. Despite having a relatively low predicted mortality risk using NESQIP, they do have a high risk of delirium and a high risk of rehab or nursing home discharge. We think overall NESQIP underestimated the risk in these patients. We examined many factors to try and understand why the MDM made certain recommendations, but on logistic regression analysis, the only factor that was significant was the patient's clinical frailty score, with each point increment in it being associated with an odds ratio for a recommendation against surgery of around 4. The other factors that we examined weren't predictive at all, which is an interesting finding. Lastly, running the MDM saved the hospital a large sum of money, and on a per patient basis, that's about 4,500 Australian dollars per case considered. In conclusion, the perioperative medicine MDM recommended against surgery in about half of patients, and did so reflecting mostly on the patient's clinical frailty score. In doing so, it saved the hospital about $4,500 per patient, and is thought to be a useful exercise for perioperative medicine going forward.